Hello, everybody, and welcome to another Polestar Pilates Hour. Today is a very special day for me because one of my heroes in my profession is Dr. Marilyn Moffat. And Dr. Marilyn Moffat, Marilyn, when I won't say when, but I think you were president of the APTA early in my profession and were like the icon of greatness and making changes in our profession. I want to share with people your bio, and it's significant because I want you in the audience to appreciate how much Dr. Marilyn Moffat has done, not only for the physical therapy population, but more importantly, for the world in health, in movement, and active aging. So Dr. Moffat right now continues to be a professor at New York University, directing the PT department, and has for many years. She still practices privately in New York. She was the WCPT president. She coordinates development international guidelines for education and standards of practice. She has been the past APTA president. That's the American Physical Therapy president. And she also has been the world physical therapy president. And I remember, I think, was there a conference in, I want to say it was like Belgium or
in the Netherlands.
In the Netherlands. It was the Netherlands. And I was there and excited to know that you were president at that time and making great changes around the world. And whatever I think about you, Marilyn, I think of all the changes and the knowledge that you've brought to our profession, specifically about active aging and about bone health and these areas that, in the Pilates world and the physical therapy world, both, we get so hung up on certain things that we put people in categories that almost fit the same thing as the Industrial Revolution of, oh, you're 65, you now all of a sudden have these limitations. Just like we would say, oh, you're 65, you need to retire, you're done working. And I think that you've had amazing leadership in that area. There's a number of books. I'm going to put them into the post-production and other things that Dr. Moffat is working on. But I do want to just express, it's an honor for us to have you on our show today, Dr. Moffat, and welcome.
Thank you. My pleasure.
Whenever I have somebody on the show, I always like first just to have you share things that you are particularly interested in right now. Like what is, you wake up in the morning and Dr. Moffat says, I can't wait to get started and work on this. What are some of your passions these days?
Well, I still am teaching full time and I'm still seeing patients on a very highly consultative basis. So those things certainly are big motivating factors in my life. I always have sort of looked at myself as being blessed in my life in that I've really loved what I've done. So it's never been arduous getting up in the morning and thinking, oh my goodness, I really don't want to do this. I don't know that I've ever had that thought. So I just sort of get up and take the day as it comes and try to do as much as I can to support the profession and to move things forward if I can.
And it's interesting you say that because I feel that way too. I feel like I love what I do. I don't ever see really retirement in sight. And I love the variability that we have. I love being able to be in academia and, I've had you as role model. I love being able to be in practice and to educate and to do research. And I have a book coming out, hopefully in the next 3 months. It's waiting for trees, I think right now is what it's waiting for. They're waiting for paper. But that'll be my first solo book that I'll publish. You've had a number of them, so I'm excited about that. But I do think the diversity around movement that our profession provides us is amazing. What are some of the latest topics regarding movement and aging, Marilyn, that we need to be aware of? I think that just for you to understand the population, we have about 1,200 people registered today for the webinar. The majority of them are Pilates teachers. I would say about half of the Pilates teachers are physical therapists as well. Mm-hmm. They come from all around the world. And we have people that are joining us today from Asia, from Turkey, from Greece, from South Africa, from Australia, New Zealand. So they come from all around the world. And I think the question that always is out there is, sort of these guidelines and these restrictions that we teach and we want them to be safe, and we want them to be able to make sure that all of our clients and our patients are having very successful movement experiences. What are some of the new or latest topics about movement with our aging population that you could share with us?
Well, I don't know that things have dramatically changed from the data that have been out there for a relatively long period of time. It's a question of whether people have been accessing that data and actually been using the data. It's really interesting because I come from an interesting background. I come again from a very strong exercise science background, and that was way before I was a physical therapist. So I bring both skills. I also had a minor in college in education, so I come from an education background as well. I also was exposed to Pilates fairly early on in the process. Through, again, Power Pilates here in New York, but also prior to that, I was exposed to Pilates through a very well-known spa. That one of the reasons I had started to use a spa is that I have traveled so much in my lifetime that vacationing for me was sort of taking time to take care of me rather than traveling to see something, because there are very few places in the world that I haven't been to. So having again, started attending spas way back, even before I was president of APTA. I then had early exposure to Pilates. And then over the years, I've had increasing exposure. I mean, certainly we've had practitioners here in New York City who were very involved, even with Pilates himself very early on. And then also with his archives and his records, which are in the Berkshires right now. So again, my exposure has been early on to Pilates. To me, it doesn't really matter the mode of the exercise. I think Pilates teachers are going to teach Pilates, yoga teachers are going to teach yoga. Physical therapists are hopefully going to integrate and use a very different kind of approach based on their education and training. The important thing is that we maximize what our individuals are doing one way or the other. And to me, fitness can't be just one component. When Carol Lewis and I did the book Age Defying Fitness, I think what we tried desperately to get across to the lay public, and this was not a book written for professional individuals, but really for the lay public, was that fitness incorporates many things. It's not just strength, and it's not just aerobic capacity, and it's not balance, and it's not posture in and of itself. All of these things are interspersed. And for one to be physically fit, they've got to look at sort of all of the parameters of every one of those in order to be a fit, healthy individual. And as I indicated early on, I'm so sorry, I thought this was off.
It happens to me all the time. It's okay. and I actively have it as my checklist to make sure that that's what I'm doing.
My phone never rings in the office, so I never think about it. I think, again, the data have been out there for so long in terms of the necessity of using exercise and physical activity. And I tend to use both terms because I think the literature tends to look at both terms, sometimes interchangeably, even though it probably shouldn't be, but certainly the data are there for total evidence for all of the parameters of what I look at as fitness. And I think, again, the data have shown, even lately, prior to COVID, I should say, when the data were coming out, that the higher levels of physical activity increase not only the healthy disease-free years, but also the chronic disease-free years in both men and women, with, again, a very high level of, basically data to support it. We know that vigorously active men and women live over 6 years longer in good health. And to me, that's really key. I don't think anybody worries about whether they live to the age of 95. They want to live to 95 in good health. They don't want to live to 95 being disabled or having participation restrictions or whatever it might be. So I think that those data, again, support the more vigorous, the more active the lifestyle, again, the healthier the individual is going to live between the ages of, 50 upwards into the late 70s into the 80s.
I appreciate you saying that. I just did a presentation on sedentarism, and one of the things that I was looking at was the research on dosing, and that dosing of activity and dosing of sedentarism had direct correlations, positive or negative, in children with cognitive development, in adolescents with emotional development, And then, of course, with all of adults with things like, metabolic disorders and physiological disorders. But it was amazing to me. And what I appreciate that you said more than anything is it's about the dosing. What is your activity level? It's not being sedentary. We know that if the average American right now or Westerner is 13 hours a day being sedentary,
Right.
that doesn't leave much time to be activity. And a Pilates class or a gym workout is not going to be enough. And I remember a study, and it was Harvard did it, and they looked at the top 20 economies, and they looked at their longevity and quality of life measures. And the United States was number 20 out of 20. And it doesn't really come as a surprise. But as they broke the information down, what they ended up showing was that the single greatest factor was community locomotion or movement. So they decided, well, let's pull New York City out and make it its own country. And New York City moved up to number 5 by their criteria. Right. And it just made sense when they realized, people, the Netherlands, Denmark, Japan, where people are walking, going to subways, they go shopping every day in France. And those countries had a significant better quality of life and longer, longevity than we did. And that life of suburbanism that we often cherish is actually not in our best interest in health. And the big question comes back is, if we want to, as you said, not only live longer, but we want to have a better quality of life. We want to be active. I look at my folks and a lot of my patients, and now me getting in, I'm right on that border in my 60th year and thinking like, what do I want for myself in my 60th year? Where do I want to be when I'm 70? Where do I want to be when I'm 80? So those are great, great, great things. Another area in that same topic that I'd love you to expand a little bit more on is the things that are the guidelines that are out there that you say, like the data that we are ignoring. Like what kind of data do you come across that typically you find that we as physical therapists or healthcare providers or fitness instructors might not be paying enough attention to in any direction? Like, what are things that you feel we're not paying enough attention to?
Well, I think there's increasing data to look at the whole arena of high intensity interval training for many, many different disorders now. I mean, initially, as you know, it was started with the very healthy populations, and people were somewhat reluctant or afraid to begin to push people into those very higher parameters. But I think, again, the data are out there for patients with cardiovascular disease, for patients with pulmonary disease, for patients with hypertension, for patients with cancer, survivors.
I'm going to say prostate cancer, high interval training greatly reduces prostate cancer.
Yeah, well, not only in terms of reducing, but also handling individuals who are battling the fatigue associated with the chemotherapeutic drugs, or again, whatever radiotherapy might be used. So there's a whole string of data now that patients with diabetes, I could go on and on in terms of listing those individuals with whom the data now
and mental health.
The support, absolutely.
The data for mental health
training. Yeah, but it's got to be done carefully and under, again, the aegis of someone who really understands the pathophysiology of what's going on with that individual. So I don't want somebody whose background is basically a high school diploma to be going in and, again, prescribing high intensity interval training for my patient with pulmonary emphysema.
And this is the spectrum. This is the spectrum we're talking about, right? A spectrum of care. And, where you and I both have come from movement backgrounds and then going into physical therapy and then into academia, and that nice combination. But I think that, one of the things that we're trying to establish is the idea of how does everybody at the appropriate level do some form of screening to know if they're in their scope of practice? And who do we associate ourselves with professionally to make sure, for example, I remember a case one time, somebody was coming just to do Pilates, and she had come for a long time, and she was working on the reformer, had feet in straps, and all of a sudden her legs were just going in really weird directions, and it was very obvious to the Pilates teacher that something was wrong. And it was Shelly. Shelly immediately called me and another physical therapist over, and we looked at her very quickly and realized that it was a neurological something going on. And so we immediately got her to the hospital with 911. It turned out it wasn't a stroke, but she did end up having a brain tumor that ended up taking her life a couple years later. But the first detection of it was inside her Pilates class by her Pilates teacher that realized this is out of my scope. And then we as physical therapists realized this is out of my scope. And we got them to the ER as quickly as possible. And a lot of times it's this communication that we need to have between the different levels. And one of the things that I've been a big advocate of, and I know you have as well, is, we go to the dentist to get our annual dental checkup. We go get our annual medical checkup. We never go get our annual movement checkup. Like we never, as far as being able to participate in something where one of the courses I teach is wellness and health promotion. How do we become more involved in health promotion as physical therapists, and how do we interact more with these service providers and trainers in the community to make sure that we can give affordable intervention that is appropriate for the pathology that person might have, and making sure that they are actively moving.
And I think it also has part of a problem in that how active are our children? Because when we don't have that kind of activity from the very earliest ages, and we know that the incidence of obesity and hypertension in kids is just appalling, it's very hard to make those major lifestyle changes as they get older. And that's why we're dealing with the non-communicable diseases in such incredible numbers, not only here in the US, but throughout the world.
Yeah.
And until we start to realize, going back to Aristotle, a sound mind and a sound body with a sound mind, when you take physical education out of the school system, again, it all takes away. And unless children have the opportunity to really be encouraged to move in organized ways. And I don't mean just to get out and walk a little bit. I mean, really get out and do that intensity of activity in the earliest days of their life. It becomes very, very difficult for that to carry out throughout life. And therefore, we wind up with the problems that we're seeing in older life.
Yeah.
But going back to scope, I think, we're all trained at certain levels. And I think the important thing is for all of us to remember exactly where that training is and how much background we have. I've often had patients come to me who've been to Pilates, and, Pilates encourages a fair amount of hyperextension activities, as you know, and some of the prone positioning. And again, my patient with spinal stenosis is often not too good with that and often made worse. So again, it's an understanding on all of us, and regardless of what service we're providing, is to realize that they've got to make sure that they understand who and what that patient and client is, or particularly in the Pilates world, who the client is. But if the client indicates they've got some pain, that adage of no pain, no gain just doesn't hold, particularly with our aging adult population. I think we've got to be particularly attuned to it and respond appropriately. My whole adage in my practice as a physical therapist is, I want muscle burn for sure if I'm trying to do major strengthening. I want, again, shortness of breath if I'm doing extreme aerobic conditioning, but I don't want pain that is a different kind of pain that says to me, whoops, wait a minute, something's wrong. I've either got to stop or change or do something, because in all likelihood, that pain is going to make that individual worse. So, here again, it goes back to understanding what our scope is, knowing what our scope is, and knowing sort of those little red flags that say, wait a minute, back off. Maybe we ought to see this individual ought to see somebody else before I go any further.
Right. I wanted to go back to something you said about the children, and the American Heart Association just came out and made a very strong statement, and particularly for parents and educators for children. And that was the idea of dosing of computer and handheld device time being associated with the metabolic and the cognitive disorders that so many of our children today are dealing with. So I thought it was interesting that, we pretty much never hear about the American Heart Association talking about our children, especially under 5. And they were saying that, this under 5 population now being babysat by their handheld devices. And we conducted a movement farm here in Southwind this summer. So we piloted it for the first time for children 5 to 11 years old or 5 to 12 years old. And the whole thing was 6 hours of movement and activity. And some of it was intense, some of it was play. They had Pilates, they climbed trees, they climbed ropes, they ran a lap around the pond. But the idea was that we wanted to see what happened. And parents brought their children and wanted to give us their handheld device in case they acted up. I seriously. And they're like, they might not make it through the whole 6 hours. If they don't, this is what we use, kind of thing. And it's like, no, they'll be fine. And we had zero problems. I mean, the children were, so engaged in being outdoor and playing and deconstructed play and organized play and conditioning. It was really amazing to us. And we took pre and post measures looking at things like endurance, power, mobility, balance, coordination, learning new activities like juggling and throwing frisbees, and a lot of things that really engaged them. And it was amazing to see what a difference it made in a week. Mm-hmm. The scores changed in these children significantly in a week. And so we're sold on it. We're going to be continuing to do it from now on for full summer programs and hopefully doing some after school programs.
The systems are so malleable, and that's the thing that we've got to remember. When you take a system at the age of 5 or 6 or 7, you can do an awful lot with changing it. When you take a system that's 77 and 78 and 79, it makes it a lot more difficult to do that.
Yeah, absolutely. Let's shift gears a little bit. Another area that you've been a major leader in the industry is bone health. Mm-hmm. And we had a lot of information about bone health. I mean, we in Polestar in particular teach our precautions and things to be aware of, and to be careful of making assumptions, because we now know that anybody that's been through chemotherapy, men included, younger adults, there's lots of other factors that can affect bone health. For me, what I always get sort of stuck on is, for example, a case where I have somebody that's been a prima ballerina their whole life. They've always been small frame. They've always moved. They've always exercised. They probably had bone density issues and were osteopenic probably in their 30s or younger. I mean, maybe they never developed enough bone density. Sometimes we see in these in some of our dancers, but they always move well. They have really good body awareness. They understand posture. They understand what compression feels like. And I guess the question I put out there is, how do we define the difference between just these blanket guidelines of that this person can never flex, when we know they're going to wipe their bottoms, they're going to put shoes on their feet, they're going to put their socks on, those kind of, put their pants on. Are there any changes at all in some of the direction, or just maybe your personal thoughts pertaining to function with active aging?
Betwixt and between on this issue, because again, I'm a very, very strong proponent of the fact that I want that bone bearing, weight bearing as much as possible. And I also want major strengthening of those muscles, because we know, again, that compression of muscle contraction around bone is a key factor in bone development and bone density, as is the weight bearing impact. The difficulty is the data also show that the flexion movement does, again, place increasing compression on that spine in terms of, again, particularly the spine that is demineralized. So for me, I try to find positions where you just don't do the flexion. That's all. I mean, I can strengthen the abdominals as strongly as possibly anyone else can without ever putting them in a crunch position. You don't have to. So those are the things. And I think, Polestar's approach is different than the traditional Pilates approach. You take more of a rehab approach. So your people are trained differently than many of the other Pilates groups that are providing Pilates services out there. But I think, I'd rather err a little bit on precaution here, but I also know I had a 93-year-old mother. I could have stood on my head and whistled Dixie, and I could not have gotten her to stop bending over to put her shoes on in the morning. And she had incredible osteoporosis. She had multiple spinal fractures. She had multiple other fractures. Every time she fell, she fractured. And I was there trying desperately to make the changes. I mean, I got her into exercising more than she ever did in her entire life. I mean, she grew up in a generation where women didn't exercise. They had their kids and that was the end of it, and, did their volunteer work and so on. That was it. So I also know that, again, people are going to flex. I just don't push the overflexing when I'm doing exercise training, because I
Right.
know I don't have to. I can get super core strengthening with all sorts of planks, with the back well stabilized, and again, without a flexion of the spine.
Yep.
So that's where I come from in terms of looking at osteoporosis. I mean, nowadays, we know there are so many drugs out there that are now being prescribed for osteoporosis. I mean, in the early days, there was very little out there. The bisphosphonates have been around for a long time, but there are so many other things now. So the daily drugs are being, again, supplanted by drugs taken once a month, drugs taken once every 6 months, injections taken once a year, you name it, and it's out there. And they're showing, again, relatively good success with altering bone density. The problem is you then have what you saw with the bisphosphonates in terms of 5 years or more of use, and then winding up with fractures in the mid shaft of the
Brittle.
femur,
Yeah.
jaw fractures, and all sorts of other things. So again, I'm always one that tries to say, you know, if you don't have to go on the drugs, if you're willing to, again, that really super healthy diet, and you do all the other things that the recommendations are telling you in terms of vitamins, the appropriate calcium and vitamin D, et cetera, and making
And
sure,
the tissue challenge.
well, and making sure that you do the weight-bearing activity to the intensity that it really does impact on the bones, and doing the strengthening so it does impact on the bones. You know, I'd much rather see it handled that way than with the drugs, but I know nowadays so many are prescribing the drugs almost, you know, without
Immediately.
second thought. And I don't know that I personally am ever going to be able to stop that. I think it's interesting that they're beginning to look certainly much more at the hormone therapy. And that's had, as you know, a very interesting series of data over many, many years. And it was because in the very early days, particularly the docs were prescribing hormones at levels that were so far in excess of what they were really needed, which then again was linked with breast cancer and all sorts of other things.
Yeah.
You know, I think there is something to say. We know for sure that premenopausal women, at least up until their late 30s, maybe early 40s, still have relatively good bone density. Once they get beyond that, if they're not doing, again, the significant weight bearing and the strengthening, then that bone mineral density goes down. But postmenopausally, it drops precipitously, at least for that period of time immediately postmenopausal. Then it tends to level out somewhat. So we know that the hormones are certainly extremely involved in bone density. So I think you're going to see more and more studies coming out looking at the possibility of, again, appropriate hormone replacement therapy as possibly being another adjunct in terms of bone management. But for me, you know, I come from a health background, and for me, the exercise and weight bearing are the components that I certainly want to look at as the key factors that I want them to do, even if they're prescribed the drugs. I want them to still get out there.
And I think that's our view. That's our viewpoint. I mean, that's our job. That's what we have to do, is make sure that they're staying active. And I was going to ask one quick question on this. One of the things that I always get worried about, and I mentioned, I'm very open about it, in the Pilates world, we don't do enough. We don't provide it. It's not part of the Pilates, but enough vertical activity of where they're walking, going upstairs, doing, you know, things in the vertical orientation, which we think is incredibly important for bone density health. But I think it's important for us as therapists and Pilates teachers to know that, you know, we need to have various different types of exercise and load that you mentioned earlier, Marilyn. What, just as far as before we shift topics on bone density?
The thing that's really, that people have to remember, if you do the same thing day in and day out, nothing happens in terms of bone. It stays the same. So that's like anything else. That's why, again, I'm always
Accommodation.
when I'm again prescribing weight bearing exercise, I'm thinking of multiple types of weight bearing. You mentioned the stair climbing. I happen to love stair climbing because in New York City, I don't want anybody to ever give me the excuse that they can't, again, do weight bearing activities of enough intensity. You know, if they live in an apartment in New York City and the apartment has even 6 floors, go up and down those 6 floors, you know, 20 times, and do it again as an intensity where those muscles are working constantly and that weight bearing is occurring. In the same way, if they don't want to go outside, I mean, New York City, as you know, has its own problems right now in terms of safety and all sorts of other things. So people are more or less probably more reluctant about going outside at all hours of the day and night. Well, if they're in an apartment building that has a relatively long hallway, walk that hallway back and forth again, and walk it in different ways. Do it one time on your toes, do it another time on your heels, do another time with, tandem walk. So you get not only balance training, but you're also getting weight bearing, and you're getting it done in a safe environment.
Yeah. Great advice. Shifting gears a little bit. So looking at sort of the future of our profession, I'd like to globalize a little bit of thinking of movement professionals, and the two terms I often use is one from, I don't know why her name's slipping me right now, from USC. She was the director at USC for many years.
You mean
Coined
Helen
the phrase
Hislop?
pathokinesiology.
Helen Hislop.
Helen Hislop. Yep. So Helen and some of her colleagues talked a lot about this idea of pathokinesiology. And then we often talk in Polestar also about performance kinesiology. So that full spectrum, that we need to understand how pathology affects movement and how we can rehabilitate that. And also, how do we increase or enhance people's performance? From a movement perspective, and with your background in movement and in therapy, where do you see us going with the conditions of the world where we are becoming more, like 80% of us are white collar workers now, sitting in front of a computer? Even if you're not white collar, your job is going to typically 80% is going to be sedentary. Where do you see us going as healthcare professionals, movement professionals, to even be able to make a dent in the imbalance of sedentarism with activity?
I love my Apple Watch. And I'm not promoting Apple, and I have no stock in Apple, so I'm not giving a pitch. But, my watch gives me an indication it's time to stand. And, it doesn't have to be a watch. It can be anything. I mean, I think we've got to get out of that constant sitting. And I think COVID had, amongst its other negative effects, one of the terrible, terrible things about COVID was people were sitting in front of computers for hours and hours and hours and hours, and days and weeks and weeks. I was guilty as everyone else, because what alternative? The only good thing about it, I had my house out in Long Island, so I could get out every day, and I had my office in my house. So I had my treadmill, and I had my weights, and I had my equipment where I could work out, which others didn't have that kind of luxury. So they sat in front of computers all day. And so there's got to be something that's built into our lifestyles that, again, brings something in our bell. I mean, I know they're doing things with eyeglasses now, of, putting things in eyeglasses that will give you a reminder. So again, I think if we can find devices, whatever it is, that will clue us that it's time to stand and walk for a few steps, and it doesn't have to be many, but at least get up out of that chair. The same thing when people are watching TV. It's the same kind of, again, sedentary, non-functional activity that really is the bane of everybody's existence in terms of lack of good physical activity. So I think the other thing in the children's end, I'd love to see more and more of those headsets, and I don't mean their little devices. I mean the headsets.
Right.
Where it automatically gives them a clue. Okay, get up and now jump around or do something that your virtual headset is. Exactly. I mean,
virtual reality.
I love Connect. I love Wii. I love all those things, and I don't care which one it is, again, because not only do kids react well to this, but even my patients do extremely well with some of the balance activities. I've used it for patients with Parkinson's disease, to get them to do that weight shift and all those things. So I think there's more and more technology that can be used in a very positive way, other than those ridiculous sitting at, their phone playing their ridiculous video games all the time.
Yeah.
And that's, the comparable analogy with adults is they're sitting before their TV much of the time.
Now, I've heard a lot of things going on these days with Rocksteady, and I know that you're a Rocksteady certified practitioner.
Right.
Could you tell people a little bit about Rocksteady?
Oh, I love this program. This is a program that was developed by colleagues of mine at the University of Indiana. And it basically was looking at something that patients with Parkinson's could do that was at a much higher level of intensity than, again, had usually been prescribed for them. And so they teamed up with a boxing clinic and established this fantastic program. Just Google Rocksteady Boxing and look at a couple of the videos that are out there. You'll see, again, the kinds of programs that are there. These individuals are all stages of Parkinson's. And again, for those of you who don't know, Parkinson's has basically 4 stages, from the earliest stages to the almost bedridden stages and almost everything in between. They get patients in stages 1 and stages 2 and stages 3. Some of them may not be able to get up out of a chair, but they're trying to get up out of the chair. Some of them with a jump rope in their hands can hardly get it over their head, but they're at least trying to get it over their head, even if they can't jump. So again, they showed that by pushing individuals to this level of intensity, they had unbelievably superb improvements, not only in terms of their physical parameters, but also the emotional and again, the mental and the interactive things that were so important for one's overall livelihood and again, their overall well-being.
Yeah, I have my students in the wellness and health promotion class volunteer and write up a couple pages of what their experience was like with the Rocksteady program.
Yeah, it's fantastic.
It's always amazing.
It really is. Yeah.
Yeah, very good stuff. Got a couple questions in here. There was one that was asking about, the Apple Watch, like how often, not about the watch itself, but how often should we be getting up out of our chairs, and how often should we be moving? How long should we be moving around in between sitting sessions?
Yeah, I don't know that there are any specific guidelines that I can give you again in terms of the data. But I like no more than 20 minutes of sitting. I think when you're sitting 20 minutes, that's about it. First of all, what I see is probably after even 15 minutes, the posture begins to go. So it's it's pretty easy to sit upright and keep yourself well supported for probably 10, 15 minutes. After that, you begin to slump down. The head goes further forward as you peer more and more into the computer. So I'm looking at about probably every 15, 20 minutes. And then I want to be up for probably about 3 to 4 to 5 minutes.
Yeah.
Here in the office, I get up, I'll walk around the hallway. I mean, we've got probably a hall walk that's about 1/4 mile. So if everybody did just that.
I know that hall.
You're right. You'd get a lot.
I take my phone calls and typically will stand up and walk while I take my phone calls now. I mean,
yeah, well, that's a great
have
way
to
to
sit
do it.
down to have that talk.
I mean, a standing desk, people have asked me about standing desks. The problem with standing desks
Still sedentary.
is that the body isn't meant to be standing all the time when you're working. So I like the combination of sitting, standing, and the back also is nicely supported when you're sitting if you have a very good supportive chair. Somebody asked in the chat I just saw, there were a couple of questions here. I'd like to probably respond if we have time, but
Yeah, go ahead.
Is it better to sit on a physio ball and standing desk? It's a little bit of everything. Again, the physio ball doesn't provide any support for the back. So it does force you to sit upright, but it also doesn't allow the back to relax at all. So a little combination of both. The ideal person would stand a little bit, sit in the physio ball for a little bit, and sit in a chair for a little bit, and just alternate activities. I said, I'm not one who likes prolonged anything other than prolonged exercise.
Yeah.
And even then, I know that the data are showing more and more and more. The reason high intensity interval training is doing so well, not only from the data perspective in terms of the physiological parameters, but it's doing so well because they can do so much more in a very short period of time and affect the physiological systems as well, if not better, than using the moderate continuous activity. So, as I said.
And that interval training is really important too. And that's why one of the things that I like to look at, obviously we think of like cross training has become so big, but the idea of mixing it up, our nervous system, our neuromuscular system, our bone structure, it's like you said, they need to be challenged, and the challenge to those tissues in our mind is part of that as well. When we think of neuroplasticity, if we're not challenging ourselves, and I think this even goes back to the Rocksteady program. It's like them being challenged. We did a Pilates program for Parkinson's for 10 years that was we said, this is not therapeutic, this is recreational Pilates. So we had stage 2, 3, even 1, 4 that came in. Sometimes he would just lay there on the table with springs on his legs and fall asleep. But everybody said that the benefits were so much better. And I just thinking like just the dopamine and the serotonin release of these challenges that we're talking about, whether it is intensity and interval training and cross training and yoga and going for a hike or dropping down and doing some push-ups. I mean, it's just just get up and move and challenge the body to a level that, that's beyond your normal comfort level. And that's where accommodation and change takes place. You know, I think that, you know, sometimes we get so caught up in a methodology, but if we do the same methodology, like you said, every day in the same intensity, then we're not challenging the tissue, the mind, or, you know, our bodies.
Right. Someone asked about, is it better that you use weights for osteoporosis rather than springs? Doesn't make any difference. It's the resistance
Load.
that's the key factor. So the load has got to be intense enough that the individual should be, again, muscularly fatigued with whatever muscle group you're working with between 8 and 12 reps. And if they're not, then they're not working at about 70 to 80% of their 1 RM. And that's, for me, the key factor in strength training. Again, I'm one that likes to get max out of what I'm doing and not have my patient worry about doing 3 sets of every single thing, because then they don't have the time. You know, it's one thing because somebody's totally retired and they can spend the morning doing exercises. Well, if you ask me to spend my entire morning doing exercises, guess what? Not going to happen. So I've got my hour, you know, between like 5:30 in the morning and 6:30, and that's it. And if I don't get everything done that I want to get done during that time, it's not going to get done. Now, it doesn't mean that I don't intersperse the other things throughout the day. I still walk, I still get up, but I won't be lifting weights during the day. I'll do some balance things because, as I said, when I walk down the hallway, I'll try to one time walk on my toes, another time on my heels, another time tandem walk, another time side step, just again to keep those balance parameters going. And I'm of an age where I need to worry about balance parameters because, as I mentioned, you know, I had the good fortune of having my mom alive to the age of 95, but she had some major, major problems and I'm very much like her in terms of body size and everything else. So I'm trying desperately to make sure that I keep that system as healthy as I possibly can.
Yeah. There was another question that popped up. I think it was Nicole asking just the question on extension with stenosis. And
yeah, you know what?
I know I have my opinion. I'd love to hear yours.
Well, you know what? I just don't do it if pain is produced, bottom line. And I'm also, I mean, most Pilates people are not going to know whether a person has a spondylolisthesis or not unless they've had an MRI or an X-ray.
Or even know what it is.
Right. And so that's another case in point where I know, again, I'm not pushing them into hyperextension. I'm talking hyperextension, you know, because I know I'm narrowing down, and with a spondylo, I've got one vertebrae slip forward of another. So I'm going to be really, really careful. So to me, when somebody gives you an indication that their back just doesn't feel good doing that, I would stop.
Yeah. And you know, one of the things,
stop and reevaluate. I mean, I don't care if it's a 40-year-old that tells you that. You know, if they say doesn't feel too good, change it or stop it or do something that, again, places them in other positions. And you've got lots of, you know, what I call tools in your toolbox. So you don't have just one exercise to use. You've got a ton of potential exercises. So you use, again, all of those that are really going to be beneficial and helpful.
And the emphasis. So, for example, distribution of movement equals distribution of force. Most people, you know, do strategically move from L4-5 and L5-S1 in their flexion. But if they had a little more movement in their thoracic or their hips.
Well, they're not going to have much in their thoracic as they get older, as you know, because the ribs are attached to the thoracic spine. So you only have a certain amount of movement in that thoracic spine, and it's relatively limited. I mean, those L4, L5-S1 vertebrae, again, are the strongest, biggest in the body. So they're built for the weight bearing and the motion, and they're the ones that are going to be affected the most. So I think, you know, we've got to look at what the biomechanics are, and we've got to, again, prescribe activity appropriately.
Yeah, good. So, Marilyn, you mentioned earlier that you were introduced to Pilates very early, and I know that Howard Sichel was sort of our connection, you know, in the Pilates world. I, of course, always knew who you were, but Howard had, you know, made that introduction and felt that it would be more appropriate for sort of what our specialty is in the Pilates industry with the physical therapy students. But I want to hear a little bit more about just your experience with Pilates for yourself. Like what is it about Pilates that turns you on, and why do you like it? Why do you want the students to learn it? I think it's good for people to know.
I want my students to know everything that's out there that their patients may be doing. And I also want them to understand if somebody is seeing a Pilates person, it has been seeing a Pilates person, and they come in and say, I've been having trouble because during my Pilates classes, I want them to know what potentially could have been done in the Pilates class that might have triggered things. So they can counsel them and advise them, and then have them go back to their Pilates person and say, maybe we can adjust things and, you know, make things perform differently. So I think the important thing is, I really want PTs to totally understand what anything patients can do. I mean, that's why we do the yoga, we do the Pilates, we've even done the Feldenkrais, we do rock steady boxing. They're strength conditioning specialists. Because it is important, because we get patients from all walks of life with all sorts of diagnoses and disabilities. And I want to be able to advise them appropriately. And it's not that I ever want to take anything away from them. I certainly don't. But if something is particularly causing problems, then I need to know about it.
Yeah, and also just the idea that, as you mentioned earlier too, there are very different, strains of yoga, different strains of
Absolutely.
Pilates, and even the
Absolutely.
level of the practitioner, who the practitioner is, and how well they're educated to work with percussion and those things. And I remember I had a
I've
case.
been through, in my lifetime, I've been through probably every Pilates fixture that's out there. Forget about the rings and the other stuff. I've seen the bands, and I've seen the balance beams being used, and I've seen everything in between and I grew up in a background of traditional Pilates. Okay. Again, I came from, prior to Power Pilates, I came from a spa Pilates that was traditionally the Pilates as Pilates was taught. And I've, again, over the years, and I still take Pilates classes whenever I can. I don't do it a lot because I vary my routine. But, I'll try anything. I tend to be a purist because I like the purism of the movement when it's done really well. But if you want to throw some props at me, that's fine. I can do that as well. And I can handle it. I can do the little balls, and I can do the magic circle, and I can do all those things. It's fine.
And Joe didn't use, Joe, he had some props, but
but he had very few. He used some springs on his bed.
He had some things for his feet, and he had a thing for breathing, and and his goal, and this is something too that I think is important that you bring up. His goal was that everybody could practice contrology every day of their life, which means that it's not going to somebody, it's practicing the philosophy of moving every day. And that was without equipment. That was being able to drop down on your, do a set of hundreds, go into swan, rock your body around, do a mermaid, and, get the movement in your body, and just you practice contrology every day. And what I find interesting is in the Pilates industry at large, when we look at all Pilates these days, that so much of it has been evolved around the equipment, but the equipment really for Joe was designed to help people become independent in his contrology exercises at home. So you're right on the money there, but we like to emphasize how important it is for people to make sure that they're teaching people the mat work. And one of the first things I did coming out of the Pilates training, again, I did my Pilates training while I was in PT school at UC San Francisco, and I did the training at the hospital there with Elizabeth Larkham and Patrice Whiteside, that was in the Dance Medicine Center there. And one of the things that I wanted to do is I wanted to take the original work of Joe. I took his sequencing, and for the next 2 years, I went through every exercise, analyzing as a different system in my body. So how does, this exercise affect my nervous system? How does it affect my digestive system? How does it affect my lymphatic system? How does it affect my musculoskeletal system? And went through every exercise and did that for a couple of years. And then I went back a couple of years later and did it as almost more of an energetic, like, what do I feel energetically in this exercise? Does it fatigue me? Does it increase my energy? And going through and dissecting everything, coming back and just thinking, like, there was such a great intuition in the original work and in its sequencing, and sort of thinking of a very early mind coming from the time of polio. Polio was big in New York, the Guthrie Smith table, which very much looks like the trapeze table, which was a couple blocks away from Joe. But it was like looking at some of the historical things going on during that time. Laban, Feldenkrais, of course, a little bit later, and Barteniev, and looking at these really deep fundamentals of movement that really should be our elements as well. We should be embracing the concepts and the philosophies of movement as they pertain to pathologies as a physical therapist, and performance as it pertains to a trainer. And I love that you always have embraced movement for your personal life, and then also bring it into a level of active aging. And I don't know, is there anything that you would want to share right now that's sort of on your mind, or anything else that before we answer a couple more questions out there in the audience. And
If I could get everybody to get up and move, I would do it. I just, and again, adopt an exercise, that's healthy and for their lifestyle. I think if I had one thing that I would do first is I'd try to get really good physical education back in the school systems.
Amen. Yeah.
I think if you ingrain early on, it becomes so much easier to follow through later in life.
Yeah.
And it's not, I've seen lots of people start intense exercise and marathon running in their 60s and 70s, but it's a lot harder and they're fewer and far between in terms of starting at that stage.
Yeah. I had the opportunity to sit on a board of directors for a school of arts for boys, a charter school here in North Carolina. And part of my role is, besides being vice chair of the board and from a business perspective to help the board do well, is that I get to create the physical education program.
Right.
So I'm super excited. And that's where we sort of started playing with the idea of the movement farm of where do we get our biggest bang for the buck in our time frames. And they're completely willing to work with us. It's a school for arts. And so we'll incorporate movement as an art as well as physical education that they have to do by the state law, right? But we're gonna exaggerate it a little bit. I think that, right now there's no recess. I mean, they've taken so many things away.
Unbelievable.
And we wonder why we have so much, ADHD and autism and other things rising. And, we just aren't letting kids be kids and move and forcing them to sit down too many hours. And then they come home and they sit down.
Right. Absolutely.
And if they're not from a wealthy family, they're not getting a lot of the extracurricular activities that, could create that intensity where as a kid, it was climbing trees, jumping off of roofs, hide and go seek. It was like play for 3 hours until the sun went down. Right. And then come in and if I had a little bit of homework to do, but I never remember doing homework as a 7 or 8 year old.
Well, and I also think too, there was an awful lot of the sport activities that were team activities, which also taught another whole parameter of life.
Yeah.
These kids often don't have as well. So,
yeah.
As I said, if I could just set up a universal program around the world, that would get.
Well, let's do that. Let's do that because we have the around the world between you and me. We have the around the world. I think that, one of the things I'm hoping to do, even with a movement farm, is just to be able to establish some statistics again that show what happens in the cognitive aspect of these children. It's like, let's, we know the research is there. I mean, I know we're fighting against bureaucracy. We did one time in Miami, we went to the Miami-Dade School District and we said, we would like to provide free Pilates mat training and mat videos that are videos back then that are specifically for children that are like 10 minutes long, about the attention span of
Right.
Elementary school kids. And we had a sponsor that would provide mats for every classroom that wanted to participate in the program. There were 3,500 elementary school teachers in Miami-Dade that year. Do you know how many took advantage of the free program to put into their classroom?
Oh my God, how sad.
And they both were retiring, hoping to get a free training to start being able to do another career. It was disgusting. But then we had to dive in a little bit. And the biggest thing was they were asking, what am I going to get paid? Am I going to get paid to take the training? And it's like, no, you're not going to pay the $1,500 to get the training.
Brent, there was an interesting comment made in the chat about making sure that you think about not only school-aged kids, but also preschool and daycare in choosing the right environments for your children. Because certainly if they're sitting and lying all day long in a preschool or daycare, that's, again, only starting to put in that habit of non-physical activity.
Yeah, there is a organization out of France called Petite Pilates.
Yeah.
And they have put together a wonderful program. We're going to be bringing their training here to the United States, but they've made it so that it could be incorporated in the family at home. They've made it so it could be incorporated from the age of 2 years old of being able to participate, or one, all the way up to teenagers and adults. And they have these card games that you play that result in having to give each other classes and move. And there's giraffes and animals and other things involved in it. Very well thought out. They had physical therapists. They had a what do they call them that do all the testing?
I'm just going to interrupt you, Brent, at this point, because it's getting close to the cutoff time. And I also want to get back to the aging environment, because I don't want anybody to ever forget that the aging community is a community that we must think about in an entirely different way. Ageism, again, has a very negative connotation here in the US. We have a population of Americans that over the age of 65, we're tripling, or at least have been prior to COVID. The numbers of individuals, again, who are now reaching 100 and over is, again, probably one of the, it's percentage wise large. So it's one of the largest percentage growing portions of our population. And the thing for us is a challenge for all of us is to keep these people, again, living in the environment that's pleasing to them and others. Hopefully it's their home environment or living with family or whatever it might be, but out of institutional environments and out of dependent care environments. So I think there's no doubt that we have a huge role to play in making.
And there's social, political, financial, socioeconomic roles that are huge. I mean, it's our voting, it's our awareness.
What's really incredible is ageism economics is a very big factor in the United States nowadays. Yeah. Nobody ever thought about ageism economics, but they are going to be almost the largest percentage of our population in terms of gross national product and also available spending income. Because we know that those between sort of 18 and probably almost 37 have very little over expendable income other than what they do for their normal activities of daily living. So again, this population potentially has the income to be involved in a lot of the things that we would like them to see them be involved in to keep themselves healthy and well. Yeah. As I said, it's a whole parameter. It's not only the activity, it's good, healthy diets. It's, again, all the things that we know of. Yeah. Yeah. Well, Marilyn, I can't thank you enough for taking an hour out of your busy schedule. I know how busy you are. I appreciate the opportunity to teach at the university every year, and it's a pleasure to be with your students. Love to have you. And I'm just going to give a little shout out to Winky Sonnenfeld, who's a colleague of mine in California. So I just see that she's been on here. So again, hi to her. So it's been a pleasure, and thoroughly enjoyed being with all of you. You're always welcome. You're all of your questions. And I know there were some interesting comments about hormone replacement therapy. I certainly am not going to say anything more other than what I said, that it is one of those things that's being looked at. There was a statement made that, it's not being prescribed. That's not true. It is. And a couple of people responded that they've been on it as well. So yeah, again, all I mentioned, there are multiple things that are being used again for the management of osteoporosis from a drug perspective. I want to see as much good data as I possibly can over time, and that's where I'm going to come from on any of these issues, whether it's related to looking at data for physical activity, whether it's, again, weight bearing, whether it's strengthening, whether it's aerobic conditioning, whether it's balance training, whether it's posture training, whatever it is. I want to be able to support with data whatever I'm doing with my patients or clients. And we know that the things like the risk of falling is one of the greatest medical costs. The falls are one of the biggest medical costs in the over 70 population, and if we can have incredible impact like you're talking about to prevent falls, to increase balance and increase function in daily activities, I mean, that in itself makes a major dent in the ability to stay out of some of the assisted living facilities and the things that you're talking about, and the socioeconomic causes as well. Well, thank you so much, Marilyn. You are an honorary Polestar grad at any time, and we appreciate your support so much in the profession, and appreciate your friendship even more. So have a great rest of your week, and everybody out there in the audience, again, I know that you're expressing the same gratitude to Dr. Moffat. We look forward to hearing from you. We have a lot of good activities coming up and more webinars in the future. We have a gait course, we have a rheumatology course coming up. We have, what else was on my mind? There's so many good things going. Just go to the website and check out what's happening. We're going to be in the NCAPTA tomorrow and the next day, presenting and introducing Pilates to a lot of the folks in North Carolina, and hope to have a good experience there. Above all things, keep those that are suffering in mind and be kind.